Hello everyone, good evening. I am Dr. Puneet, a consultant neurophysician from Kanpur, and today I will talk about subarachnoid hemorrhage. Hemorrhage at the surface of brain because of rupture of blood vessels within the subarachnoid space. Actually, brain have three coverings: pia mater, which stick over brain and follow its gyrus and sulcus, then arachnoid matter, and then dura mater, which is outermost covering. So, uh, between arachnoid matter and the pia mater, there is subarachnoid space, which is filled with CSF, cerebrospinal fluid, which provide nutrition to the brain, and along with this there are blood vessels, major blood vessels of the brain, which form circle of Willis. So this circle of Willis at the base of brain is situated in subarachnoid space. So whenever there is either trauma, direct trauma to these blood vessels of the brain, that may lead to the leakage of blood and lead to the blood at the surface of brain and lead to this subarachnoid hemorrhage. Or beside trauma, there might be aneurysmal rupture that lead to this subarachnoid hemorrhage. Now, how these aneurysm form? So the major risk factor is smoking, uh, tobacco smoking, and this hypertension, along with some sympathomimetic drugs, substance like cocaine, and some connective tissue disorder, um, autosomal dominant polycystic kidney disease. So there are various causes for formation of these aneurysm, but the preventable one is smoking and hypertension. So hypertension that lead to direct damage to the wall of blood vessels in the brain, and that lead to the degeneration of tunica media and internal elastic lamina, and that lead to then the radial force of this blood lead to outpouching. So this all outpouching with a neck is known as aneurysm. This kind of aneurysm is known as saccular aneurysm or berry aneurysm because it has a neck. Okay, sometime the whole wall, whole of the wall get whole of the wall get damaged, and that lead to the dilatation and elongation. So that lead to fusiform aneurysm. So this fusiform aneurysm, if there is dilatation and suppose elongation and tortuosity is also there, then this is known as this dolichoectasia, and these kinds of aneurysm is more common in posterior circulation and may lead to mass effect on a cranial nerve or subarachnoid hemorrhage sometime, or sometime thrombosis might occur here in these sites. Okay, then dissecting aneurysm is because of uh, a dissection of intracranial or extracranial blood vessels, which might be spontaneous or associated with some trauma, and generally associated with some trauma. And if it is in extracranial dissection, then the blood is in between intima and media, so it lead to stenosis. And if it is intracranial dissection, then blood is between media and adventitia, so that lead to the dilatation or formation of this dissecting aneurysm. Sometimes mycotic aneurysm due to infection or bacilli, especially Streptococcus viridans, may lead to the direct damage to the wall of blood vessels and may lead to the formation of aneurysm. So mainly three type of aneurysm. The most common type is saccular aneurysm, and the most important risk factor for these saccular aneurysm is hypertension and smoking. And how patient generally present with um, sudden onset severe headache, thunderclap headache. Patient, if they are conscious, then they describe that doctor, it is worst headache of my life. I am not been able to tolerate this. Okay, and sometimes they are this severe headache is associated with loss of consciousness, neck pain, and when you examine patients, severe neck rigidity might be there. Sometime preceding sentinel headaches might be there, but it is present in 10 to 40% patient only. And in this sentinel headache, the headache is intensity is similar to that of thunderclap headache, but the duration is short. And these headache, these sentinel headache is because of uh, minor minor rupture with subarachnoid hemorrhage, or hemorrhage in the wall of vessels, or sometime elongation of the aneurysm. Okay. Now, what other manifestation? So, in other manifestation, this aneurysm, especially PCA, this MCA or and PCOM aneurysm that lead to the third nerve palsy, and basilar artery and SCA aneurysm that lead to again third nerve palsy with pupillary involvement, and then cavernous portion of IC aneurysm that lead to 3, 4, 6 nerve palsy, 3, 4, and 6 cranial nerve palsy. So these are the manifestations. Now, how will you diagnose these cases? So with the help of CT, plain CT, non-contrast CT. Why non-contrast? Because contrast also appear black in CT. Blood also appear, contrast appear white, and blood also appear white in CT. So when you suspect that the patient is having subarachnoid hemorrhage, so first go for CT. Suppose you CT didn't show anything, and you are strongly suspicion that patient is having subarachnoid hemorrhage. Now, at what time you suspect that it is subarachnoid hemorrhage? So there are a few important indicators, such as if there is a new onset headache at age more than 40 years, and associated with physical exertion, and it is thunderclap variety of headache, most severe type of headache, and if headache is associated with the loss of consciousness, or if neck rigidity is there, or in passive flexion of neck is difficult, then you should suspect this. And if suppose CT is normal, then go for lumbar puncture. In lumbar puncture, you find blood or sometime xanthochromia. Xanthochromia appear after 2 hours, and it persists for several weeks. Okay, so this is the diagnosis. Now, how will you treat? So, firstly, treatment of an incidentally find aneurysm. How will you approach? So, if you find an aneurysm incidentally, then first of all, you have to control patient blood pressure and advise him to stop smoking. Now, the natural history of these aneurysm is this, that there is 1 to 6.5% rupture every year. So annual rupture incidence is 1 to 6.5%. So if aneurysm is located posteriorly, or if it is large in size, more than 10 mm, if it is giant aneurysm or expanding aneurysm, or suppose female, in old age female, the chance of rupture is also high. So suppose you get posterior circulation aneurysm, or large size aneurysm, or aneurysm with multilobulated aneurysm, means sac with aneurysm with a daughter sac. Okay, so or during MRI, if you get contrast enhancement at the wall of aneurysm. So these are the findings which suggest that it might get ruptured. So in all these cases, you can go for either neurosurgical clipping or endovascular coiling. This neurosurgical clipping, actually this is at some studies, especially ISAT study, that is International Aneurysmal uh, um, aneurysmal subarachnoid aneurysmal trial. So International Subarachnoid Aneurysmal Trial, it shows that endovascular coiling is safer than this neurosurgical clipping. But suppose if there is an MCA aneurysm, MCA aneurysm is close to the surface, and it is often wide neck. So wide neck aneurysm coiling is difficult. So in wide neck aneurysm, you go for clipping. In clipping, you clip or clip the neck of aneurysm with while the parent artery remain normal. Okay, so you just occlude the aneurysmal neck, and the parent artery flow is normal. Then this coiling Guglielmi coils. Actually, we put multiple coils within the sac of these aneurysm to block these aneurysm, and this coil promote thrombosis, and in this way this coiling help, and it is very beneficial in posterior circulation aneurysm, where neurosurgery is difficult, very difficult and very lethal also. So in posterior circulation, these aneurysmal coiling is very good kind of treatment. Okay. Okay. Then suppose this is for incidental. Now suppose patient present with to you with hemorrhage. So in that case also, risk of rebleeding is very high, especially in initial 2 to 12 hour. And so once patient come to you, you just see his neurological conditions. Neurological condition may be worse due to adjacent brain injury. So adjacent brain injury, so check for his neurological status, and then maintain ABC, and then um, fluid and hydration should be measured. Always try to prevent this hypotension and hypovolemia. But also remember that if your systolic blood pressure is more than 160, it may lead to rebleeding. So BP should be less than 160, but it should not be less than 100. Okay, so because hypotension and hypovolemia is dangerous, it may exacerbate delayed cerebral ischemia DCI, vasospasm and DCI, which generally occur after 3 days, 3 to 20 days. Most of the cases develop within 7 to 10 days. Okay, and for this vasospasm or delayed cerebral ischemia, to prevent this, we use nimodipine. Nimodipine, actually, it has anti-vasospastic effect, so it prevent vasospasm. And one benefit from this neurosurgical clipping is that during this procedure, you can also remove the clot. And actually this clot has irritant property. Blood and blood product, it lead to irritation of the adjacent blood vessels and lead to this vasospasm, that is sustained and prolonged contraction of these blood vessels, and that lead to infarct. Okay, so if you remove the clot also, the chances of vasospasm decrease, but it is not like so, because during this procedure you also altered the 3D anatomy of this subarachnoid space, and you are touching the blood vessels, and you are retracting the brain. So these things lead to the vasospasm. So okay, then after this, as I already discussed here also, if MCA aneurysmal rupture is there, then go for neurosurgical clipping. Or if posterior circulation aneurysm is there, then best is this coiling. And ISAT, International Subarachnoid Aneurysmal Trial, suggests that this coiling is better in terms of less mortality, especially in older. So it is preferable in older patient. And so that's all about this subarachnoid hemorrhage. Thanks for watching. Thank you.